Hi all, welcome to another session of vertical integration. Today we have chosen a very clinically and academically relevant topic, that is urinary tract infection. For this discussion we have Dr. Girish Kumar sir, Principal, Amrita School of Medicine, Dr. Purnima, Associate Professor in Microbiology, and Dr. Janaki, Assistant Professor in the Department of Obstetrics and Gynecology. I'll start off with a question to Dr. Purnima. Dr. Purnima, UTI is a kind of a broad umbrella term. So can you help us in a definition and classification of urinary tract infections?
Okay, so you can't exactly have a proper definition for a UTI as such. As you said, sir, it is an umbrella term. So it encompasses all the infections that start from the renal cortex, pelvis, to the ureter, urinary bladder, and the urethra. Right. So any infection that happens in any of these areas will be included under UTI. Now, that's the definition of UTI. Right. So, shall I go on to classify it?
Please.
Okay. So, to classify UTI, we have different types of classifications. One is the anatomical, then depending on whether it is hospital acquired or community acquired. So, anatomical, you can call it as upper UTI and lower UTI. So, renal cortex, pelvis, and ureter will be the upper UTI, and urinary bladder and urethra, any infections there will belong to the lower UTI. So your pyelonephritis, anything like that will be an upper UTI, and a cystitis or urethritis, all that will be lower UTI. Yeah. So the next classification is community acquired and hospital acquired. Right. So community acquired is anything that is from the community. The pathogens will be different for that. Okay. And hospital acquired is when there is an inpatient admission, there is an admission and there is a hospital stay, and there is a catheter. Most of the time a hospital acquired UTI is because of an indwelling urinary catheter. Right. So that is the next one. Another classification is whether it is complicated or uncomplicated. So uncomplicated UTI is generally when it is a non-pregnant female with a urinary tract infection. So that is called an uncomplicated UTI. Complicated is when all the other categories are there. Okay. Pregnant with any kind of structural or functional anomalies of the renal system. Any of that will fall under the complicated UTI. So this is how you classify UTI.
Okay. Just in continuation, can you also explain what is asymptomatic bacteriuria so that...
Okay, so asymptomatic bacteriuria, ideally, when you say UTI, the first test that would come to your mind is a urine routine or a urine culture. Yeah. So it always happens. You might not actually ensure whether there is symptom or not. So it's like for every patient, we would go for a urine culture. And ideally, a urine culture is... you should do it only if there are symptoms present in the patient. Right. But there are certain situations wherein even if there is no symptom, you should consider it as significant. Okay. So that is, for example, in pregnancy. Okay. So it is a routine urine culture that you would ask for, and this is categorized as asymptomatic bacteriuria. Okay. And secondly, in patients who are about to have some kind of surgeries, prostatic surgeries, etc., wherein you would expect a bleeding, in them also this asymptomatic bacteriuria is significant.
Okay. Yeah. So by now we would have understood the common terms one need to be aware of in the topic urinary tract infections. And also, Dr. Purnima, can you tell us what are the common organisms which you usually see?
Okay. Most commonly, the first pathogen that you would see is the gram-negative bacilli E. coli, which is the uropathogenic E. coli. Then you have other enterobacterials like Klebsiella, Proteus, all those enterobacterials. Then you would have other gram-negative bacilli like Pseudomonas, Acinetobacter, etc. And then the gram-positive cocci like Staphylococcus aureus, Staphylococcus saprophyticus, coagulase-negative staphylococci. Then moving on to fungi, we'll have Candida species. Almost all Candida species can be pathogenic. And then coming to the viruses, you have adenovirus and BK virus, which can be pathogens. And parasites, very rarely they cause urinary tract infections. One common example is the Trichomonas vaginalis parasite and Schistosoma hematobium. These can cause UTI. Okay. Yeah, so that's about it.
To Dr. Janaki, how does the female urinary tract kind of predispose or increase the incidence of urinary tract infections?
Yes, as we all know, in females, they are more prone to develop urinary tract infection because of many reasons. One anatomical reason being, female has a shorter urethra compared to male. The urethra is only 4 centimeters, whereas in males it is about 25 centimeters. Right. So that is one reason. Then close proximity of the external urethral meatus to the nearby organs like vulva and lower third of the vagina, where there is increased chance of bacterial infections. Okay. And also any procedures like catheterization or any activity like sexual intercourse also can increase the chance for urinary infection in females.
Okay, right. So what are the usual risk factors one should be thinking about once somebody presents with a UTI, and what are the common clinical features which you see when a patient presents?
So risk factors when we see you can take children and adult. Children, the most common risk factor what we see in our practice is children are not taking water. That is the most common thing which can be easily correctable. Okay, you can ask them to take plenty of water so that the urethra or urinary tract will be flushed with the water. Okay, so that is a easily correctable thing. Then in children, very young children, reflux can also produce some sort of urinary tract infection. And that is not exactly what we are discussing here. That's why I'm not going there. But the common problem in young adult, that's what we are discussing now. In non-pregnant female patients, we can see without any reason, we can see many urinary tract infection. It's also again they are not taking adequate water or they are using public toilet. These are the reasons for that. Okay, but in male, if you see the male urinary tract infection, like Madam told, non-pregnant urinary tract infection, especially in male, should be considered as a complicated UTI. There will be structural abnormalities in that urinary tract. In that prostate comes common problem. What we are treating is prostatitis and prostate related urinary tract infection. Then diabetes is one of the common cause for urinary tract infection in our country. Patients on steroids. So all sorts of reasons like Madam told, complicated UTI means there is a structural abnormality that will be there. But generally, what we see is without any reason, many patients, especially female patients, come with urinary tract infection. We will not be able to find out a reason for that. But in male UTI, you definitely can find out a reason. Diabetes, you know that it is because of the increased urine, which is there will be some autonomic dysfunction and increased urine in the bladder that contains high levels of sugar. That is a good culture media for bacteria. These are the common reasons for urinary tract infection. Then in hospital, like you have catheterized a patient, that patient can come back with repeated UTI, some previous procedure. That patient also can come back with urinary tract infections. Generally, if you see track the patients, most of the patients come without any reasons. But there are some subset of patients definitely you can track for some abnormality in the urinary tract, and that will be the reason for that.
Clinical features?
Clinical features, the most common clinical feature for urinary tract infection is we all learn in MBBS high degree fever, chills, rigors. These are the common clinical features. You no need to doubt that will be urinary tract infection. Okay. Then they can have pain during micturition, dribbling of urine, hesitancy, urgency, all features of prostatic enlargement that also can be there. But some patients like diabetic patient, they present with low back pain. There is a classical finding in diabetes and urinary tract infection. You can see many patients just complain, I have low back pain last 3-4 weeks. If you check the urine, it will be positive. They will not have any clinical finding because their immune system is not that good to respond to that infection. They may not have fever, they may not have chills, nothing will be there. So only low back pain will be there. Some patients, like you were discussed previously, asymptomatic bacteria. Without any symptoms, you can see bacteria or pus cells in the urine. Okay. So the most common finding will be always fever, rigor, chills, all these things.
So did mention about just touched upon pregnancy. So Dr. Janaki, how does this pregnancy and hormonal changes influence the rate of UTI?
Yes, in pregnancy, ladies are more prone to develop urinary infection. Right. That is mainly because of the compressive effect of the uterus over the ureters and the bladder, and there will be incomplete voiding of urine, and that leads to urinary stasis, which leads to infection. And also the urinary pH, it changes in pregnancy. It becomes less acidic, and so it favors the growth of organisms.
Right.
And also, there is more chance of asymptomatic bacteriuria in pregnancy, as ma'am said. And that can cause various complications in pregnancy also, like preterm labor, preeclampsia, all these can happen because of this infection.
Now we have covered the basic risk factors, the common symptoms we encounter and all. Suppose a patient comes to you and you suspect urinary tract infection. What will be the basic investigations you will be sending from an OPD?
So whether the patient come to emergency room or OPD, the first line of investigation will be simple urine test. Okay. So you see the clinical findings, you ask for a urine routine examination. What we see in that is pus cells. Pus cells can be there in urine without a urinary tract infection also, especially elderly females. You can see a lot of epithelial cells will be misdiagnosed as pus cells by the treating doctor, and that will be another problem when you are treating elderly individual. But urine shows pus cells, that is most important. But remember, in most of the female patients you can see 5 to 8 pus cells, that may be considered as normal. But in a male patient, even if you see 1 or 2 pus cells itself, you should have a high index of suspicion that this patient may have urinary tract infection. Second line of investigation is any patient who is having pus cells in the urine, suspected urinary tract infection symptoms, we have to ask for a urine culture. Okay, that we have to ask the patient to take a midstream urine and ask for culture. One culture sample is enough. Like unlike your blood culture, we may be taking 3 or 4 samples. Here, one culture sample is more than sufficient. And one more thing you have to remember is some patients repeatedly come to your OPD or emergency room with repeated urinary tract infection. So we have to always check the previous culture report also. We have to see the same organism is growing or a different organism is growing. So normally we do all these things. We do a urine routine, we do a urine culture, and if suppose you suspect a severe infection like pyelonephritis or sepsis, then you can ask creatinine values, other urea, creatinine, and other markers of infection. You can ask for CRP, you can ask for procalcitonin levels, you can ask for ultrasound. These are special investigation which can be done only in special subset of patients, not in all patients. Routinely we ask for urine routine, urine culture. Then suppose you are suspecting prostatic enlargement, you have to look for the size of the prostate, you have to look for post-voidal residual urine. But remember not to do PSA in acute phase. This is the most important mistake done by most of the doctors. They ask PSA in the acute phase. PSA will be definitely elevated even in a normal UTI. So try to avoid that test. Otherwise, most of the tests what we do in routine practice is creatinine, CBC, CRP, procalcitonin. If your hospital is having facility for that, you have to ask for that ultrasound abdomen, and sometimes we may ask for a X-ray KUB to see whether stones are there or not. So the routine investigation we do.
Okay, sir did mention about urine routine. So, but it is very important that you collect urine in a proper way. Dr. Purnima, if you can just tell us how to collect a proper urine sample.
I would say a proper urine sample collection is very much necessary for a urine culture.
Okay.
So I'll talk on the basis of urine culture. So whenever you advise the patient, be it a male or a female patient, to take a urine sample for culture, you'll have to instruct them certain things before they take the sample. The first would be, first you have to provide them with a good container, which is a wide-mouthed, screw-capped universal container. It is sterile. You'll have to provide them with that, and you'll have to mark the patient details, the name, the MRD and all that on the container. And then you'll have to instruct them to wash their genitals or privates thoroughly with soap and water, and to pass the first stream of urine and to collect the midstream or the second stream of urine into the container. So that is how you would take the midstream urine sample. Then we spoke about catheter associated urinary tract infection, wherein we need to take the sample from the Foley's catheter. So ideally a Foley's catheter will have a sampling port. So that is from where you can take the urine sample. If the sampling port is not available, you will have to make the area sterile and use a needle and syringe above the level of bifurcation after clamping it, and then draw the urine sample. So we should never collect the urine sample from the urobag. That is a big no-no. You should never collect the urine from the urobag because it is definitely going to be contaminated and colonized with a lot of other unwanted flora. So that should never be taken. So Cotti sample, that's how you take. Then there are a few other sample types that are acceptable. One is the suprapubic aspirate. So this is what is basically recommended for very young children. So in them a suprapubic aspirate can be taken. So these, and then there is another sample type called as a 3-day early morning sample, and this is specifically taken in cases of tuberculosis. So the early morning sample, the first voided sample, the full sample is collected on 3 consecutive days, and this is the sample that is recommended for tuberculosis.
Okay. And also, sir, also mentioned about urine routine and urine culture. Can you explain it in more detail about the interpretation part? How do you?
Okay. So, in urine routine, as what sir was saying, what we would generally look for is a pustules, bacteria, etc. And there are a few other tests that can be done along with it, like the screening assays, wherein it's giving you a provisional diagnosis as to whether there is an infection in the urinary tract or not. So, one example for that is the Grice nitrate test. Then you have the leukocyte esterase test. Then so these are a few dipstick assays which can be done, and it is giving you, they are very sensitive, but you can't say it is very specific. So they're giving you an idea that it is probably there, and based on this you can go for the urine culture. So this is called the reflex criteria. This is about the stewardship practices that can be performed. So once these are positive, you can go for the urine culture. So in urine culture, what we would do is, it is culture. So generally we make use of culture media. We use either the conventional culture media, which is blood agar or McConkey agar, or another culture medium, which is CLED medium, which is cysteine lactose electrolyte deficient medium. So all these culture medium, before going into that, I would like to say that there is a concept called as significant bacteriuria. So this is based on concept which is CAS concept of significant bacteriuria. What we are trying to say is, as we were previously discussing, urine as such is sterile.
Right.
But the lower portion of the urethra, since there is, as ma'am was saying, the close proximity to the anal orifice and vaginal opening, there is always a chance of commensals and colonization in the anterior urethra. So as the urine is flowing down, it tends to get contaminated with these commensal flora, and whatever you're growing on the culture media might not be the pathogen. Right. So we need to say that in order to say that this is a pathogen, there needs to be a significant amount of bacteria or the pathogen in the urine sample. So that is significant bacteriuria, and we say in microbiological terms, we say it should either be more than or equal to 10 to the power of 5 colony forming units per ml. So that is a count that we say. Having said this, in catheter-associated UTI, if a patient has got symptoms, not the conventional symptoms that you would see in a normal UTI, if there are symptoms but the colony count is only say approximately 10 power 3 or so, it still can be considered significant. It needn't be as high as 10 power 3. So if there are symptoms in a catheter sample, this can be taken as significant bacteriuria.
Thank you. Dr. Janaki. UTI in postmenopausal women, what are the special considerations you're going to take?
So in postmenopausal age group, similar to vagina, the urethra as well as the bladder mucosa also undergoes atrophy. And that is why they are more prone to infection. The epithelial lining becomes very thin. So ideally we can give prophylactic antibiotics in case they are getting more recurrent urinary infections. And also phytoestrogens, mainly it is because of the lack of estrogen. So phytoestrogens or hormonal replacement therapy can also be beneficial in some patients. Local application of estrogen creams can also be beneficial.
Okay. Thank you. So Girish sir, can we discuss the management of UTI?
Normally, when we are discussing about simple urinary tract infection, we will only start drugs like norfloxacin, ciprofloxacin, ofloxacin, like that. These are the ideal drugs. Routinely, we give norfloxacin 400 milligram BD. That will be enough for most of the patients. But you may be knowing that in India, a lot of tuberculosis cases are there. We are left and right using these quinolones. So we may not recommend quinolones as a first line treatment for urinary tract infection, at least in our country. You can go for alternative drugs like augmentin, may be a good choice. When we compare with the quinolones, they are not a good choice for gram-negative infection, but that can be tried. Or you can try cefixime. Okay, that can be tried. But the best drug in the class is quinolones. So we routinely give norfloxacin 400 milligram BD, ciprofloxacin 500 milligram BD, ofloxacin 400 milligram OD or 200 milligram BD. These are the common choices. Right. But if you are admitting, when we are working in emergency room, we'll have to admit the patient. So most of this patient, already madam has told, it is predominantly gram-negative infection. E. coli is the most common. 85% of the urinary tract infection is due to E. coli. So you can start ceftriaxone or cefotaxime 1 gram BD. that will be the routine choice in emergency room. If the patient is coming from a different hospital, multiple procedures are done, or patient is already on catheter, you can even think about ESPLs. Then if you are thinking about ESPLs, then the treatment is, and the antibiotic will be, choice of antibiotic will be different. You have to go for a higher antibiotic like piperacillin, tazobactam or meropenem. But remember, ceftriaxone, cefotaxime, all are good for a normal UTI. They are sick, but they are not in sepsis. But when the patient come with severe sepsis, hypotension, shock, they are not a good choice. You will have to go for a higher antibiotic like piperacillin, tazobactam or meropenem. And during the treatment, you have to initiate the investigations. Like when the patient come to emergency room or OPD, you have to start investigating. And once you get the culture report, that is very important. Madam has already told 10 to the power of 5, that much bacteria if it is present, and the culture shows which is sensitive to your antibiotic, you can continue the antibiotic. Suppose you have started on a higher antibiotic and your culture report shows sensitive to ceftriaxone, you can de-escalate the antibiotic. But one important thing we all should remember is, suppose the patient is improving with your antibiotic. You have started ceftriaxone for a urinary tract infection. Patient is improving, but your culture shows it is resistant to ceftriaxone. But you are seeing there is a significant clinical improvement in the patient condition. Then you can continue that antibiotic for some more time, and you can wait. And before changing to higher antibiotic, we can change. Because problem with urinary tract infection, especially in complicated urinary tract infection, this patient is going to come to your clinic or emergency room repeatedly. So suppose you start higher antibiotic first itself, you will not have a choice after some times. So we have to be very careful. We have to choose the antibiotic properly in urinary tract infection, because these patients will repeatedly come to your department. Once the patient develops urinary tract infection, second, third infection will be very common, especially in diabetes or immunocompromised status.
Dr. Jani, can you tell us about the management of UTI in pregnancy and what is the usual choice of antibiotics?
Yes, in pregnancy, ideally we have to screen for UTI in each trimester. And the ideal choice would be nitrofurantoin in pregnancy, because it is both safe for the fetus and the mother. And in the first trimester, but it is advisable to avoid nitrofurantoin. In second and third trimester, we can use nitrofurantoin safely. The next choice would be any penicillins, whether with or without beta-lactamase, we can use in pregnancy. It is safe. And cephalexin also is found to be safe in pregnancy. And those who have repeated infections and have developed pyelonephritis, then it is always advisable to continue nitrofurantoin throughout the pregnancy as a OD dose, daily dose. Can be continued.
Okay. And Dr. Purnima, we did talk about COTI, and also can you kind of emphasize on what are the challenges which COTI brings in, and also mention about the concept of MDR infections?
Okay, so as we were previously talking on, COTI is catheter-associated urinary tract infection, which is basically a device-associated infection, a hospital-acquired infection. So any patient who's got a Foley's catheter and it's been there for 48 hours or so, they are prone to develop this catheter-associated UTI. So the initial term, you can call it as catheter-associated bacteriuria. This can further be classified as catheter-associated UTI, which is symptomatic, and then you have catheter-associated asymptomatic bacteriuria. Right. So why we need to have these two definitions is because not always what you grow from the urine sample who's from a patient on Foley's is pathogenic. It might be a colonizer, might not need treatment. You will just have to remove the Foley's. That is the only thing that might be needed. Okay. Whereas in another patient who's on Foley's and who's showing some symptoms. So as we were discussing the hesitancy, frequency, urgency, etc., these symptoms might not be seen in a patient who's catheterized. Okay. And what we can ask them is, one, look for fever, as Sir was saying, or the renal angle tenderness or suprapubic tenderness. So these are a few things that can be looked for in a patient who's got a Foley's catheter. Okay. So in them, you will take the sample, and that's what is sample collection. I've already mentioned how you would do that from a Foley's. Another thing I would emphasize here is it is not at all recommended to send the Foley's catheter tip for culture. That is almost always seen we get requests saying it needs to be done, but it is pointless to do that because always it is going to be a colonizer there. So that is a rejection criteria for urine sample collection. Now, and always we must ensure that a closed system of drainage is maintained. Never disconnect the urobag from the tubing and then try to collect. And all the time while handling the urobag and any kind of cleaning of the meatus etc. is done, consider it as a sterile procedure and only do it. Please take appropriate precautions while doing it so that you don't introduce any infection into the Foley's and cause a UTI in the patient. Now, coming to the concept of MDR, which is multi-drug resistant infection. So MDR infections are generally seen with more commonly with hospital-acquired infections. So how you would categorize a particular isolate as MDR is when we have our culture reports. As sir was saying, during the culture reports, we report a panel of antibiotics. So there are different tiers that are reported, and there are certain antibiotics that are reported only in urine samples. Some that are not reported in urine samples, like your macrolide antibiotics, erythromycin, azithromycin. These are not reported with urinary isolates. So then, if when we test and you will see the susceptibility reports, whether it is susceptible or resistant. If more than 3 groups of antibiotics are resistant, it is considered a multi-drug resistant bug.
Okay.
So in them, as sir was saying, whether it is ESBL or carba resistant, you will have to pick and choose appropriately according to the antibiogram that's come out. So almost always the hospital-acquired infections are multi-drug resistant with Klebsiella or E. coli or Acinetobacter. Any of these pathogens can be multi-drug resistant.
Okay, thank you. Girish sir, so what are the key things one should keep in mind while managing a pyelonephritis? And also if you can mention some words about TB and fungal UTIs.
First, we'll discuss about TB and fungus because any patient who comes with repeated urinary tract infection and your culture is negative, there are multiple reasons for culture negative urinary tract infection. One is already you might have started antibiotic or someone else might have started antibiotic. You are likely to get a culture negative UTI or a simple viral UTI. You may get a culture negative. But repeatedly, if you are getting culture negative UTI and if the patient come back with every time come back with a urinary tract infection, then you have to strongly suspect tuberculosis. Like Madam told, 3 samples are required, 3 early morning samples are required that we can ask for tuberculosis examination. Fungus is also again like that. Repeatedly you are getting a culture negative. This one, especially in diabetic patients, fungal urinary tract infections are very common nowadays. But treatment is very difficult for fungus and tuberculosis that we'll discuss in a different class. Now you have asked about pyelonephritis. That is one of the major problem we face in emergency room. We may not face that problem in OPDs because pyelonephritis patient will be very sick. Patient will be sometimes hypotensive. They may come to your ER with a shock. All these things are common. So how to investigate, how to treat, there is a different issue. Investigation is whatever we have discussed last session. We have discussed about urinary culture, ultrasound, CT. So many investigations are required. But treatment is very, very clear. Any patient who is admitted with severe sepsis, hypotension, shock, you know how to treat them. You have to start fluids, you have to start noradrenaline, you have to start higher antibiotics. But basically, if pyelonephritis, suppose you get a case of pyelonephritis, you have to investigate the case thoroughly because pyelonephritis in a patient, like a normal patient, will never come to your emergency or ICU with pyelonephritis. They can have some immunocompromised status, especially diabetes. In our country, diabetes is very common, and Kerala also it is very common. So diabetes is the most common cause for pyelonephritis. In that type of patients, sugar control is most important than starting any random antibiotic. Sugar control, most of the time we may not achieve the sugar control without treating the urinary tract infection, and we may not be able to treat the urinary tract infection without controlling the sugar. So all these things are very important. So treatment of sepsis, septic shock is same like what we treat in most of the other sepsis. But here we have to be little more careful, more investigations are required. Most of the time we require a CT scan to find out whether there is pus in the kidney, surrounding the kidney pus is there, or any stones are there, strictures are there, malignancy is there. All these things are basic CT is required.
Okay. With that, we have come to the end of the pre-prepared questions. One last round to everyone. From the UG perspective, under the topic of UTI, what are the things, key things, just the topics what a student should know, and from an exam perspective also for them, and any other things if you have missed, then probably you can talk on that.
Urinary tract infection is one of the common case which come to our OPD or our clinic, but unfortunately they are not exam cases. Okay, but even then you have to learn about urinary tract infection. One short note or essay can come in general medicine examination, describe in detail about urinary tract infection. Here everything comes. We already discussed everything about urinary tract infection. There is only thing. Unfortunately, these cases are not kept in examination, but a student has to learn to practice medicine. They have to learn about urinary tract infection. They should be able to treat the urinary tract infection. That is very important.
As far as microbiology is concerned, a UG person must know about the common etiological agents, then the different samples that can be collected, then something on a basic idea on what happens in the lab, how a urine culture is done, how you would do the interpretation of a report, and how you would interpret a antibiogram that is coming out of it. Yeah, so these are the most common things that are asked in microbiology.
In obstetrics and gynecology, mainly as Sir said, it is a clinically important topic, and we encounter a lot of patients even in the gynaec OPD as well as in labor room. Many of the patients come with pain and diagnosed as UTI. So clinically it is a relevant topic, and for practical purpose as exam case usually it's not kept, but you should know the details for theory exam.
Okay, thank you all. Thank you.